graduate, 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term care facilities, nursing homes, with patients in their private homes, from doing my clinical rotation here in the United States, from two graduate medical education programs, and four internal medicine residency in Troy, Michigan, Springfield Family Medicine Residency, Springfield, Illinois, from various observerships and externships, from my various preventive health care fairs, where I've had the opportunity to have hands-on experience. With research experience at UT Southwestern in the psychiatry department, working with Dr. Caroline and Dina Down, and also a master's in business administration with an emphasis on public administration at Davenport University, Grand Rapids, Michigan. I'm currently involved in preventive health care and also applying for residency this year. And I want to thank you all for logging into Dr. Drchikitomentoring YouTube show, broadcasting live. It's a show that is designed to help healthcare professionals to stay abreast of trending healthcare topics. And it's designed for those in residence and also for nurses and also other healthcare professionals and also for patients too to be able to learn to identify common healthcare problems that they might encounter daily as they go around in their clinics, as they round in the wards, and also even as they experience it too. Dr. Chiquito mentioned preventive healthcare preventive practice is actually proud to be in the forefront of providing you with these trending healthcare topics. I want to thank everybody who has been interactive, following all the topics that we've been talking about. We've talked about a lot of interesting topics. We've talked about viral upper respiratory tract infection. That was on Monday, and then on Tuesday we talked about pulmonary tuberculosis. On Wednesday, we actually had a trip to the homeless shelter, but unfortunately, we were not able to go because some members of the team were not able to make it. So I'm going to create more awareness about this coming up this week, and hopefully by next week, it's something that we are going to be doing every week, trying to go out into the community to be able to create awareness about this preventive health process, and also to be able to see if we can be able to provide free health assessments to them too, and also to just to visit them and create awareness about this opportunity. And then also on Thursday, which is today, we're gonna talk about normal labor and delivery. It was supposed to be the Ulster session, the health assessment, which is gonna be done once every week. But it's gonna be on Fridays, and that's gonna be constant from now. There's gonna be Fridays every day, and we'll have an Oscar session about how to like about how to do physical exams and what what we should be able to do as we do physical exams. The physical examination is a very important component of every healthcare professional's training, and that's something that we are actually hoping that we can be able to help healthcare professionals to be able to learn. So today I'm talking about normal labor and delivery. I have a case study and I'm just gonna read about the case study. So it's in the office, and you have a 24-year-old married female who presents with nausea and vomiting. Her vital signs are pulse 82 per minute, temperature like 8.6 degrees Fahrenheit, respiratory rate is 16. Blood pressure is 130/7 millimeter, mercury height is 156 centimeters, weight is 62 kilograms, 136.4 pounds. So history of present illness, some more story about why she came in. Some more history about why she came in. So 24-year-old Asian female presents with complaints of nausea and vomiting for the last several days. She feels more nauseated in the morning and also complains of breath pain. Her last menstrual period was 7 weeks ago, and before that, her menstrual periods have always been regular with a 28 to 29 day cycle. She was married 8 months ago. Is sexually active with her husband and has never been pregnant. The patient denies abdominal pain, fever, or vaginal discharge. She has been a one fast per day smoker since her teenage years. She's not on any medication, does not drink or use recreational drugs. The patient migrated to the United States 5 years ago and does not recall her vaccination history. There is no history of sexually transmitted diseases, but she has never been tested for STDs. Recently, she has been experiencing some constipation. Otherwise, her bowel and bladder functions are regular. She doing well at her office where she works as a secretary handling emotional stressors. Review of system are unremarkable. Hospitalization of procedures never. Other medical problems none. No allergies, no current medications, and family history. The father is healthy at 55, the mother is healthy at 45. Maternal grandmother died of breast cancer at 60. She has one older sister who is healthy. Social history is listed above. Educational history includes attending social events and watching movies. So that's the story. At this point, I'm pretty sure you must have some differentials at the top of your mind. You might be thinking it could be urinary tract infection, which we talked about, an infection of the of the urinary tract. Yeah, of the urinary tract. It can also be cervical cancer, which was about organ. Could be endometritis, an inflammation of part of the womb. It could be ruptured ovarian torsion. I'm sorry, it could be ovarian torsion, which is twisting of the ovaries. It could also be sarcoiditis, which is an inflammation of part of the womb. It could also be um, uh, the any of the things that we actually just said above. But hopefully, as we go along, we can be able to learn why it's normal level of delivery and not any of those depressions that we actually talked about earlier. So normal level delivery, I'm going to read this article. It's a wonderful article that I wrote about normal level delivery, which is something that is encountered normally in the primary care setting and also in the obstetrics and gynecology setting. And so I'm going to talk about labor. What is labor? Well, it is a spontaneous physiological process by which a fetus is expelled from the uterus to the outside world. So it's a spontaneous process most of the time. Epidemiology, child, actually, I was able to find out data about C-sections. I'm not about normal vaginal spontaneous delivery. So C-sections by childbirth at C-section decreased 50% in the United States from 1996 to 2006 and comprised nearly 32% of births in the United States and Canada. That's actually from Wikipedia 2013. So what else should we be thinking about as we go through these different, as we see someone who has all these symptoms? Well, it could be a retained product of abortion, it could be a molar pregnancy, it could be corneal myoma or abscess, it could be an ovarian tumor, it could be an endometrioma, it could be appendicitis, it could be cervical cancer, it could be pneumonia, which is pain during menstrual period. It could be an early pregnancy loss, especially if she was pregnant earlier on. Or it could be a hemorrhagic shock, if she was bleeding and she had a shock. It could be hypovolemic shock. It could be placenta previa. It could be sarcoiditis. It could be ruptured complicating cyst or ovarian follicle. It could also be spontaneous abortion or threatened abortion. It could be an ovarian torsion, as mentioned earlier. It could also be urinary tract infection. This could be either of these things that we've actually listed and which that we'll talk about coming up on this show. So prenatal care, the woman actually, once a woman is diagnosed with pregnancy, she has to undergo prenatal care to be able to ensure a safe delivery and a safe labor. So it actually refers to the regular medical and nursing care recommended for women with the goal of providing regular checkups that allow doctors and midwives to treat and prevent potential health problems throughout the course of the pregnancy, while promoting healthy lifestyles that benefit both mother and child and has played a part in reducing maternal death rates and miscarriages as well as birth defects, low birth weight and other preventable health problems. So actually it's a combination of regular checkups, healthy lifestyles, and that has actually been shown to have a very been very efficacious in being able to prevent birth defects, low birth weight, and other preventable health problems. So the prenatal care consists of monthly visits to the doctor during the first two trimester. So from week 1 to 28, you have to go every month. And then fortnightly visits to doctors from 28 weeks to 36 weeks of pregnancy. So that's every 2 weeks. So that kind of shortens it down to every 2 weeks from the 28 weeks to the 36 weeks. Then after analysis kit you have to bring with you. And then also during that time, there has to be an assessment of the parental needs and family dynamics. So, what are the components of the prenatal care visit? What do you expect as you go to see your physician? Well, there has to be a collection of the mother's medical history. You have to be able to tell the physician how you have been feeling, how you have been faring, what has been going on in your life. And also the physical exam, so which normally consists of checking the mother's blood pressure, the mother's height and weight, the pelvic exam, the cervical examination, the Doppler fetal heart rate monitoring, the mother's blood and urine test, and also discussion too with the caregiver. Then the ultrasound is also normally done, and they're normally done during the second trimester at approximately week 20. They're normally done to diagnose pregnancy, which is very uncommon. It's actually quite complicated just to do an ultrasound and then get an indication for it. Then also to check for multiple fetuses to assess for possible risks to the mother. Example, if you have a miscarriage, if you have a blighted ovum, an ectopic pregnancy, molar pregnancy. To check for fetal malformation, clot, foot, spinal bifida, left palate, and clenched teeth. And then also to check if there's an intrauterine growth intervention, and also to check for the development of the fetal body parts. For example, the heart, the brain, the stomach, the skull. Make sure that everything is going as it should. And then also to check the agnostic fluid and the umbilical cord. And also it's also done to determine the due date, which is actually based on measurements and also the relative developmental progress. And then, but most times it's actually done whenever there's an abnormality, whenever you suspect there's a problem, then that's when you do it. But and most times it's done at 7 weeks to confirm the pregnancy and to ensure that it's neither molar or ectopic. And then at 13 to 14 weeks, it's done at that time as in some areas to evaluate the possibility of Down syndrome, but typically it's done 18 to 20 weeks. At 24 weeks, it's done to evaluate the size and to verify the placental position. And then the cervical examination is also indicated at that time to see whether the fetal membranes are intact or ruptured. Now, if the membranes are ruptured, then you have to defer the vaginal exam, and then you have to do a sterile sexual examination to avoid any infection. In women with suspected membrane rupture to assess the cervix and confirm the diagnosis. And then also you have to check for the presence or the absence of fetal meconium due to the risk of meconium aspiration. That's if the membranes have ruptured. And then also you have to check if the uterine bleeding is present and excessive. The cervical status too is also indicated, so it's best evaluated by digital examination. So with that, we're checking for dilation. Is the cell is dilated and normally it's measured in 0 to 10 centimeters. And also effacement, which is described as zero, no effacement, where the cervix is 3 to 4 cm long, to 100% effacement, where there's complete thinning of the cervix. And then the fetal station, which should be expressed as the number of centimeters of the living bony edge of the presenting part above or below the level of the ischial spine. The maximum denominator is 5. So 1 centimeter beyond the ischial spine corresponds to plus 1 over 5 centimeters. And then also, it is also done to check for the presentation and the position of the fetus. So the presentation refers to the part of the fetus at the cervical opening. That is bridge, vertex, or shoulder. The position describes the relationship of the presenting part to the pelvis. Example, left occipital anterior. So if there's uncertainty about any of these, we have to do an ultrasound. And then also to check for the approximate size of the maternal pelvis. That's also called a clinical pelvimetry. I'm going to continue in 2 minutes here. So that's also called, I apologize for the interruption. That's also called clinical pelvimetry. Laboratory test include rhesus type and antibody screening. So this test would detect antibodies potentially causing hemolytic disease of the newborn. And then also the antibody test or the stool test is also done. The regular antibody is also done. documentation of infection by healthcare providers. And then also varicella immunity should be determined too. Urine floating should be done, and that's actually with a biscuit. That's actually a baseline for comparison. For comparison, if there's assessment of if assessment of renal function is performed later in pregnancy. Urinalysis is also needed. A urine culture is also needed because pregnant women who are asymptomatic, who have asymptomatic bacteremia should be tested because they are at high risk of developing pyelonephritis. And then hepatitis B antigen testing also is recommended for all pregnant women who and this is especially done to prevent perinatal transmission. Hepatitis C antibody is also needed. Syphilis testing, this can be done with the General Disease Research Laboratory Test, also called the GPRL, the RPR or Rapid Plasma Reagent Test, the fluorescent troponin antibody absorption test, the troponin palladium hemagglutinin assay, and then the microhemagglutinin assay test. Then the gonorrhea culture, gonorrhea antigen is also needed. Chlamydia testing is also needed. This is actually from the American Congress of Obstetrics and Gynecology, and they recommend chlamydia testing for all women at the first prenatal visit. HIV is also needed. This is also a recommendation from the American Congress of Obstetrics and Gynecology. Thyroid stimulating hormone is also needed. Testing for type 2 diabetes is also needed too. Normally it's actually done with A1C at the first prenatal visit, and then you repeat the screening at 24 to 28 weeks for women with A1C less than 6.5. Or you can do the 75 gram 2-hour oral glucose tolerance test at 24 to 28 weeks of gestation. Or you can do the two steps. Normally the two steps is done if the 75 gram is actually positive. So the two steps is screening with the glucose challenge test to give a 50-gram oral glucose challenge test for screening, followed by diagnostic testing in women who screen positive. So so plasma glucose is measured 1 hour later. And then a value of more than 130 or more than 140 is considered elevated in women, elevated, and the women who have an elevated value are now given the 100-gram 3-hour oral glucose tolerance factor. Oral glucose tolerance test for definitive diagnosis. A pap smear is also indicated too. Disease septococcus culture is also indicated, and that's culture of both the vagina and the anus. Then the sickle cell anemia or sickle cell trait screen is also needed to detect sickle cell. And then also it's also important to offer varicella vaccine after measuring the varicella antibodies. For second trimester, you have to consider um, um, the triple the test for Down syndrome. So that's actually done to test for trisomy 16 and 18. So opposite of protein is increased the neural field defect, and it's decreased in trisomy 21 and 18. Human chorionic gonadotropin is increased in trisomy in trisomy 21 and decreased in trisomy 18. And then unconjugated estriol is decreased in trisomy 21 and trisomy 18. Then integrate A is increased in trisomy 21 and normal in trisomy 18. So some precautions. This test actually should not replace amniocentesis if it's 35 years or older. And then the trisomy 21 risk increase is based on multiple pregnancies. Normally, if it's a single pregnancy, a single teen pregnancy, we measure it measure it at 35 years, and then if it's a twin gestation, we measure it at 43 years. So how do we confirm it? Well, sometimes most times we do an ultrasound to confirm the gestational age. And then if the sex test was actually less than 15 weeks, then you have to withdraw it. You also have to consider amniocentesis too. So the new protocols about the first trimester screening, I actually looked into that, it's actually something that is actually being investigated right now. Being able to do this test in the first trimester. repeat hepatitis B surface antigen, repeat HIV test. If at high risk of preterm labor, consider bacterial vaginosis screening, consider fetal fibronectin. First trimester labs, that's 35 to 37 weeks, reduce respiratory screening. So now we're going to talk about the modes of childbirth. There are lots of tests that are indicated during pregnancy. This is actually able to make sure that the fetus is actually safe. So, but after that, the pregnancy was spontaneous labor. That's labor that occurs by itself, and that's as a result of gradual encasement and dilatation of the uterine cervix, as a result of rhythmic uterine contractions of sufficient frequency, intensity, and duration. Um, and um, and um, and that's the definition of spontaneous labor. So that it happens by itself. It's not induced. But it can be induced, and more than 22% of women actually undergo induction of labor. In the United States, vaginal birth actually occurs without any surgery, and cesarean section, that's when you have to undergo surgery to be able to remove the neonates. We talked about the rate earlier on. Physical examination, well, labor is actually has to be done before labor, and then labor is divided into three stages. So the first stage, you have the membrane rupture. So once that happens, you have to minimize digital examination, and it can be confirmed by at least two of the following. There are three tests that are actually necessary to be able to confirm membrane rupture. So that's positive nitrogen pH test result, evidence of microscopic swelling, pattern of the dry fluid, that's called the census, and then observation of amniotic fluid in the vaginal valve, that's called the pulling side. And then also it begins with regular uterine contraction and ends with complete cervical dilation at 10 p.m. It has a latent phase and an active phase. The latent phase begins with mild irregular uterine contractions that that um, that soften and shorten the cervix. The active phase begins at about 3 to 4 p.m. of cervical dilation, and is characterized by rapid cervical dilation and descent of the presenting fetal part. Now the second stage of labor begins with complete cervical dilation and ends with the delivery of the fetus. Once there's crowning, that's at the plus 5 station, then delivery is imminent. And that's when the fetal head bulges the perineum and the head moves through the birth canal. Now, the second stage should be considered prolonged if it exceeds 3 hours if regional anesthesia is administered, or 2 hours in the absence of regional anesthesia. In nulliparous women and in multiparous women, the second stage should be considered prolonged if it exceeds 2 hours with anesthesia and 1 hour without it. Third stage of labor, the period between the delivery of the fetus and the delivery of the placenta and the fetal membrane. So at this point, the child has already been delivered. So the delivery of the placenta often takes less than 10 minutes, though it may last as long as 30 minutes. So once it becomes more than 30 minutes, then it's actually considered prolonged. And if it's prolonged, then what do you do? Well, you have to administer prophylactic administration of oxytocin or other uterotonics. That's like prostaglandins or ergot alkaloids, and then clamping and cutting and control traction of the umbilical cord. So the mechanisms of labor, I'm going to talk about it. And it involves the cardinal movement. This involves changes in the position of the fetus head during its passage in labor. So there are actually 7 discrete sequences. So number 1 is engagement, the widest diameter of the presenting part with a well-placed pen, where the largest transverse diameter of the fetal occiput is the biparental diameter enters the maternal pelvis to a level below the plane of the pelvic inlet, and the presenting part is at zero station at the level of the maternal ischial spine or pelvic accommodation. So that's engagement. And then number 2 is descent. This is the downward passage of the presenting part through the pelvis, which occurs intermittently with contractions and rate is created during the second stage of labor. Flexion, as the fetal vessel descends, it encounters resistance from the bony pelvis or the soft tissues of the pelvic floor, which results in passive flexion of the fetal occiput. The shin is brought into contact with the fetal thorax, and the presenting diameter changes from frontal, which is 11.0 cm, to suboccipital phlegmatic, which is 9.5 cm, for optimal passage through the pelvis. The third one is internal rotation. As the head descends, the presenting part, usually in the joints and smooth flexion of the head brings the base of the occiput to come into contact with the inferior margins of the pelvic symphysis. Upward resistance from the pelvic floor and the downward forces from the uterine contraction cause the occiput to extend and rotate around the symphysis, followed by delivery of the fetus head. Now the next one is waist fusion and external rotation. So when the fetal head is still at resistance, it untwists about 45 degrees left or right, and then it returns back to the original anatomic position in relation to the body. The next one is expulsion. After the fetal head is delivered, further distance brings the anterior shoulder to the level of the pelvic symphysis. The anterior shoulder is then rotated under the symphysis, followed by the posterior shoulder and the rest of the symphysis. So that's seven cardinal movements: engagement, descent, flexion, internal rotation, extension, restitution and external rotation, and expulsion. So the process of delivery, like we talked about, in history is very important. In focus, history is very important, and then prenatal care, and then also you have to confirm the estimated date of delivery. You have to confirm the frequency and the time of onset of contraction, the status of the amniotic membranes, whether spontaneous rupture of the membranes has occurred, and whether the amniotic fluid is clear or meconium stained. You also have to confirm if there's fetal movement, and also the presence or absence of vaginal bleeding. Physical examination, like we talked about, the maternal vital signs, fetal presentation, the assessment of fetal well-being, frequency, duration, and intensity of uterine contraction, abdominal examination with unified maneuvers. I'm going to talk about that a little bit. This also is really interesting, being able to elicit the position of the fetus with that, and it's very interesting, and in residency, you actually got that by midwives. Most midwives have actually gotten surprising results with that. It works really good, and you can also be able to reposition the fetus prior to labor. So the first maneuver, the examiner places both of his or her hands on each upper quadrant of the patient's abdomen and gently palpates the fundus to the tips of the fingers to define which fetal pole is present in the fundus. If it's the fetal head, which is still hard and round, in a bridge position, a large nodular body is felt. The second maneuver involves palpation in the para-umbilical region with both hands by applying gentle but quick pressure. The purpose is to differentiate the fetal spine and have resistance structure from its smooth, irregular mobile small parts to determine the fetus position. The third maneuver is the suprapubic palpation by using the thumb and fingers of the dominant hand. The examiner ascertains the fetus presentation and estimates its station. If the presenting part is not engaged, the movable body can be felt, and this also allows for an assessment of the fetal weight and also of the volume of the amniotic fluid. The fourth maneuver involves palpation of the bilateral lower quadrant with the aim of determining if the presenting part of the fetus is engaged in the mother's pelvis. So the examiner stands facing the mother's feet, then with the tips of the first three fingers of both hands, the examiner exerts deep pressure in the direction of the axis of the pelvic inlet. In a cephalic presentation, the fetus head is considered engaged if the examiner's hands diverge as they trace the fetus head onto the pelvis. Then at this point also, a pelvic examination with several globes is also needed too, and this actually allows the examiner to be able to examine the following parts of the pelvis. The degree of dilatation, which we talked about earlier, ranges from 0 to 10. And then the first then, which is assessment of the cervical length, which is actually reported as normal, as 0 to completely effaced, and then also position too, whether it's anterior or posterior, and then also the consistency, whether it's soft or firm. Then also another thing that is also important is the Braxton Hicks contraction, which must be differentiated from true contractions. And the Braxton Hicks contractions occur no more than once or twice per hour, often just a few times per day. They are irregular and do not increase in frequency with increasing intensity. They resolve with ambulation and change in activity. When they lead to labor, when they are not Braxton Hicks contractions, then they may start as infrequently as every 10 to 15 minutes, but usually accelerate over time, increasing to contractions that occur every 2 to 3 minutes. They tend to last longer and are more intense than drug-specific contractions due to cervical change. So palpation of the presenting parts of the fetus allows the examiner to establish the patient by quantifying the distance of the body to the presenting part, uh, which is related to the maternal ischial spine. The zero station is lying in the plane of the maternal ischial spine. Now, another term that is important is lightning. That's the physical change of the cells because the tissue cell is advancing into the pelvis. So that's something that the mother feels progressively as she can report or say that the baby has become light and the shape of the mother's abdomen may change to reflect difference of the fetus. And also her breathing may be relieved because tension and dry from the disease. And also, there could also be more frequent urination because of the added pressure of the urinary bladder. So the intrapartum management of labor, what actually happens when labor starts? Well, equipment needed, external fetal fetal heart rate monitor. And one thing about it's actually used to be able to monitor the fetal heart rate, be able to see how the baby is doing. So category one, normal fetal heart tracing and just continue expectant management. The category two, you have interdeterminate fetal heart tracing, and these tracings require close observation and intervention to determine whether the patient has acidemia. Category three, abnormal fetal heart tracings, and they require immediate intervention. These are not reassuring and are indicative of fetal acidemia. So if the fit does not improve with conservative measures, then movement should be made towards the baby. Some other instruments include the internal fetal heart rate monitor, that's the fetal stab electrode, the intrauterine pressure catheter, the Foster, which is a handheld metal instrument with made a sensor that are applied to each side of the fetal head. When do you use it? Well, when there's a prolonged second stage of labor. When it's actually associated with less fetal hematoma formation and fetal delivery time compared with a vacuum, but it's also and then also, but then it's also associated with increased maternal trauma and laceration. It's also associated with lower risk of maternal hemorrhage and a better chance that the mother might be able to deliver vaginally in subsequent pregnancies. The vacuum consists of a suction cup that attaches to the fetal head to assist with extraction. So traction pressure is created by negative pressure handle system. And there are different types of the vacuum. There is the metal cup vacuum, there is the plastic cup vacuum, and a mushroom shaped vacuum cup that combines with the advantages of the metal and plastic design. And it's actually used when there's a need for urgent delivery because of fetal distress, poor maternal food power, or maternal medical conditions that contraindicate strong fiction. I've used it before, like had good success with it. Some complications that could occur include hematomas, blood clots, vaginal and perineal lacerations, and then once admitted, the external psychometric monitoring for the onset and duration of the uterine contractions and use of the Doppler device to detect fetal heart tones and rate should be started. Uh, and we actually talked about all the other equipment that is also needed too. And then also you also have to start an intravenous aspect too. The laboratory tests that is needed include CBC, complete blood count, blood packing and screening, urinalysis. So in the first stage of labor, when admitted to the labor and the delivery suite, a woman having a normal labor should be encouraged to assume the position that she finds most comfortable. So they should be encouraged to walk, encouraged to sit, to be able to lie and to rest in a less lateral distribution position. And management includes periodic assessment of the frequency and strength of uterine contractions and changes in the cervix and the fetus station and position and monitoring of the fetal heart rate at least every 15 minutes, particularly during and immediately after uterine contractions. In most obstetric clinics, the fetal heart rate is assessed continuously. So most times, they just hook the fetal heart rate monitor off, and then you can always go in and check on the script. And then also the second stage of labor with complete cervical dilatation, the fetal heart rate should be monitored or auscultated at least every 5 minutes and after each contraction. So when there's second stage arrest, then just continue observation and expectant management of operative vaginal delivery by forceps or vacuum assisted vaginal delivery or cesarean delivery. Delivery of the fetus, you have to position the mother, and it could be in any of these positions. It could be supine with her knees bent, that's the basal rhythmic position. This is the usual choice. It could be lateral, the same position. It could be fascial seated or squatting position, or on her hands and knees. Delivery maneuvers include the head is held in weak position until it's delivered, followed by suctioning of the oropharynx and larynx and names. That is actually not recommended some recent guidelines. So check the fetus neck for a wrapped umbilical cord and promptly reduce it if possible. If the cord is wrapped too tightly to be removed, the cord can be double clamped and taut. The fetus anterior shoulder is delivered with gentle downward traction on its head and chin. And then without pulling, apply gentle posterior traction of the head at an angle of 45 degrees to deliver the anterior shoulder. Subsequent upward pressure in the opposite direction facilitates delivery of the posterior shoulder. Gentle anterior traction of the head to deliver the posterior shoulder. Then the rest of the fetus should now be easily delivered with gentle traction away from the mother. And then if this hasn't been done previously, the cord should be clamped and crossed. And then the baby should be vigorously stimulated and dried and then transferred to the care of the waiting attendant or placed on the mother's abdomen. Actually, pretty advised to encourage some skin contact between the mother and the child once the child is actually born. And then the clinician can facilitate placental delivery by applying gentle traction on the umbilical cord with one hand, applying vertical pressure just superior to the pelvic symphysis with the other hand to prevent inflaction of the uterus, and administering intravenous oxytocin to expedite the third stage of labor. Oxytocin should be started at delivery of the anterior shoulder. And also, once the placenta is actually delivered, you have to manually inspect the placenta after delivery to check for any retained placenta fragments that increase the risk of postpartum hemorrhage. At the third stage of labor, so that actually constitutes the third stage of labor, which is delivery of the placenta. So how do we know that there's placental separation? There are three pathognomonic signs of placental separation. So the uterus contracts and rises, the umbilical cord suddenly lengthens, and then there's a gush of blood. So those are the three pathognomonic signs, and once that happens, you know that there's actually placental separation. Then delivery of the placenta usually happens within 5 to 10 minutes after delivery to 30 minutes. So once it's more than 30 minutes, then it has come to one. And active management involves prophylactic administration of oxytocin or other uterotonics, including prostaglandins, exosacolins, cord clamping and crossing, and controlled cord traction of the umbilical cord. So we actually talked about the techniques of delivery. For pain control, there are some medications that have actually been proven to be efficacious. Mepiridine 25 to 50 milligram IV every 1 to 2 hours, or 50 to 100 milligram iron every 2 to 4 hours. Fentanyl 50 to 100 mcg IV every hour. Nalbuphine 10 milligram IV or iron every 3 hours. Butorphanol 1 to 2 milligram IV or iron every 4 hours. Morphine 2 to 5 milligram IV or 10 milligram iron every 4 hours. We can also use regional anesthesia as an alternative, and they include epidural, spinal, or combined. So some important points include that an article from Anderson et al. That found out that delayed cord clamping, that's more than 180 seconds after delivery, improves iron settings and reduce prevalence of iron deficiency at age 4 months, and also reduce the prevalence of neonatal anemia without apparent adverse effects. So that's something that is actually pretty interesting, and I'm looking into that in terms of successes that have been found on the wall. There's cervical ripening too. The favorable cervix is defined by the Bishop score, intravaginal prostaglandin before oxytocin is initiated. Most of the time you give misoprostol or prostaglandin E1, which is also called spice effect, and it's most often used for cervical harassment. So 25 to 50 mcg is given vaginally, buccally, or sublingually. Prostaglandin E2, also called dinososum, can also be used for cervical harassment. It's actually more expensive than misoprostol and has an increased rate of capital, causing many contractions. A bladder catheter can also be used for harassment too. Um, and then also another important point is that planned vaginal delivery of a term singleton bridge is actually no longer appropriate. So you have to wait to there's regular contraction. So further diagnosis, this lady actually was pregnant, and we already talked about how to handle the prenatal care, the labs to do, the imaging, and then also the process of normal labor delivery, which is very important. We encounter it every day. It's very important to be able to know how to take care of the mom and to see her every day in your clinic. To know what steps to be able to expect as you go into a prenatal care, which is very important. And then also to be able to know about the process of labor, the techniques of labor, of delivery, and we just talked about all of that. So what's the ICD code for pregnancy? Is ICD 9650, ICD 10333. And I have a power question that is designed to be able to help us to understand the article, to be able to help us to read the article. And the power question is childbirth by C-section increased 50% in the US from 1996 to 2006 and comprised nearly 33% of deaths in the US and Canada, true or false. So that's actually listed in the article, and I want to encourage you to check it out. If you answer the question, you have a chance, you have a shot at winning some of the prizes that we have from some of our sponsors. We have a lot of sponsors from various residency programs, sponsors from various organizations. And if you win it, you can be able to win a prize. If you answer the first one, you can be able to win a prize. The drawing will be done on Saturday when I do my broadcast for my work, Fertility Work, to live the live work by the Beginner Informer Society. So I'm going to go to the next section, which is the interview, the residency interview question of the day, which is pulling up my slide here. Yeah, so we're actually in the next section, which is the residency interview question of the day. And the question is, why are you interested in this program? So this is actually a good opportunity for you to be able to explain the reasons behind your interest in this program, leading to the application to the program. So it's advisable to have a comprehensive research of the program policy, which includes the curriculum, the structure of the program, the location of the program, the availability of procedures, and the opportunity to specialize. Most programs have this information on their website and also can be able to answer any questions that you have. And it's also very important to list the policies that actually attracted you to the program. So an example of an answer could be, I'm interested in this program because of the diverse patient population, the inpatient exposure and the outpatient exposure, the location of the program, the procedures available, the structure of the curriculum, and the faculty, staff, and residents who are dedicated to teaching. And the opportunity to specialize after residency, and which has convinced me that this program will be a perfect fit for me. So that's an example of how you could probably answer an question like that. It's very important to be able to convince the program that you actually research the program, that you actually know about the policies of the program, that you actually are convinced that you can be able to be a perfect fit and be able to receive your training and spend the rest of your 3 years of the career in residency and spend 3 years in that program. So at this point, we are gonna go into the next section, which is the residency program of the day, the teachers residency program of the day. I want to encourage everybody who actually is interviewing. It's a very exciting time. You actually get to meet new people. You get to learn about various programs here on the road. So it can be very exciting. So I want to encourage you to be able to share your stories, post on my wall, send me a message. I have a Facebook campaign for residential campaign 2014. There are lots of things happening, and lots of interviews, and lots of programs that are actually seeking candidates for residency. So it's very advisable to be able to stay abreast on all of these. So I would encourage you to post on my wall, to contact me, and I can be able to share a story with you if you are also interested in one of these people. Our residency program of the day is Toledo Family Medicine Residency, Pro Medica Family Medicine Residence, and I'll talk a little bit about them. They have 2 programs attached to the hospital, Pro Medica Hospital. So they have Flower Hospital Family Medicine Residency, and then they also have um, St. Luke Family Medicine Residency. Flower Hospital Family Medicine Residency. It's a 3-year program offering 6 PGY positions. They have the opportunity to be able to learn best in a friendly and supportive family environment with academic excellence. And we also want to produce, physicians that can be able to make a difference in the community as a family physician. They actually have they actually use the Pro Medica Flower Hospital, which is a 294-bed facility in Sylvania, Ohio, which is accredited by the Joint Commission. The hospital is a level 3 emergency trauma center and is the regional leader for inpatient adult psychiatric services, as well as the largest provider of radiation oncology in Northwest Ohio. This is thanks to the Eastman Cancer Center. We also have a senior and assisted living facility um, located in that area, and then they also have a sports medicine fellowship. Um, the sport pass rate is actually 98%. The faculty to resident ratio is 1.4. They are accredited by the Accreditation Council for Body Medical Education, approved ROC full accreditation in 2003. Um, about the area, they have um, lots of things to brag about in terms of the community, in terms of the educational um, 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 community. They have the University of Toledo, the Bowling Green State University, the Lawyers University, the Owen Community College. They have a lot of things in terms of education and sports. They have a lot of things that you can be able to explore in terms of culture. The Toledo Ballet, the Toledo Museum of Art, the Toledo Opera, the Toledo Symphony. Um, and then the curriculum is actually pretty interesting. Most of the residents actually go to one more rotations in their first year, which include cardiology, community medicine, family medicine, inpatient, general surgery, orthopedics, pediatrics, psychiatry. The transcripts from medical school, personal statements, rules, letters, and then also a valid ECFMC certificate if applicable, and also a USMLE scores 1 and 2. We have some quick criteria about the USMLE scores which can be found on their website, and they're also very friendly to international applicants. They have information about their interview selections and how you can be able to arrange the interviews and be able to contact them. They also have another so the two programs that are located is St. Luke's and Flower Flower Hospital Medical Flower Hospital Family Medicine Residency, and they are also on Facebook. And their Facebook post for today is a link that was shared by Hot Seat, and it's top tier tips about this week of safety tips before they head out for the night. So yeah, that's by Gina Berries. So you can be able to check that out. Be able to read about it. Halloween is coming up soon, and it's very important that we learn about these tips and tricks and what the cultural tips about. So healthcare news, a lot of exciting things happening in healthcare. We are 24 into the show. I'm just gonna talk about some of them. The Twitter chat that we just had with the National Resident Matching Program that was actually pretty interesting. It was designed to be able to help residents, to help candidates, be able to learn about updates in the batch, be able to learn about what's going on in the match and be able to and give them an opportunity for questions. So um, some some top tweets by the NRMP was that rank other youths satisfied by both applicants and programs. Very important to know, and that the NRMP runs an algorithm. There's less than 6 weeks away from the early registration deadline of 11:30, and you can be able to do that. To register to avoid the 50 dollar fee. They don't swap positions, they use the process called the source. You know about the source, which has actually replaced the ensemble. And if you sign a match participation agreement, that's a violation of, if you sign a contract, that's a violation of the match participation agreement. And then to be eligible for soap, you must register with NRNC and also, and that will make you soap eligible. Um, and then also in terms of number of applicants that have been registered already, there are 25,000 applicants who have been registered already. So the number can actually change, and there's still time. One January 31, 2014 is actually the deadline. And you can find all of that information on my Facebook page and also on their website too. Some other trending things that are actually happening in healthcare include from the putting up my slides here. From the American College of Physicians, we have a new guideline for stage 1 to 3 chronic kidney disease. So I invite you to check that out on their webpage. From the ACP internet, we also have change to Medicaid device state. That's actually by doctors. That's actually something that has actually been talked about. Ohio is actually one of the states that have actually been talked about too. And then also from the American Academy of Family Physicians, there's still time to report your CME. The reporting deadline is October 26th. And then and then also they're also inviting your opinions about how to make the scientific assembly better. So your opinion counts. Then from the Institute from the IHI, they have a conference today by 2 o'clock Eastern Time, and the topic is who is conversation ready, how healthcare can respect end of life issues. So that's October 24th, 2 to 3 p.m. Eastern Time. You can be able to enroll. It's a free seminar. And from the Society for Teachers of Family Medicine, there's introduction to careers in academic family medicine. That's actually one of my interests, curriculum development. Is an interest to looking at all the residency programs and all the curriculum and how the curriculum is structured. So I'm actually doing some research on that, and I should be able to present the data soon on how the curriculum is structured and what aspects we're able to get from this curriculum. And then also from the World Health Organization, trending news include games in tuberculosis control at risk, and what's in the name. And then from the IAFP, International Family Physician, they just had a conference recently. It was a wonderful conference, and they have lots of people on their Facebook page you can be able to check out. They have the flu vaccine awareness campaign. They have all that information, and they also have tools for your classes too that you can be able to check out. From the American Psychiatry information, from the American Psychiatry Association, we have a mental health parity. October 2013 marks 5 years since passing of the Mental Health Parity and Addiction Equity Act. So check that out, and you can be able to join the conversation on Twitter. From the American Psychology Association, they have in the news, they have America's Mood Map, an interactive guide to the United States of Attitude. They have homeless to have a child of addicts, counseling youth and spirituality. So they have a lot of information about mental health issues, which is actually very important. This is actually something that we see every day in our clinics. From the American Medical Informatics Association, they have upcoming conferences, January 30 to February 1. There's the iHealth 2014 conference, February 13 to February 16, 2014. There's the ACMI Research Symposium in Scottsdale, Arizona. The iHealth conference is actually in Orlando, Florida. The April 7 to April 11, 2014, we have the Joint Summit on Translational Science. That's in San Francisco. May 19 to May 21, we have the Academic Forum Annual Conference in Ann Arbor, Michigan. And then from the American Congress of Obstetrics and Gynecology, the American Congress of Obstetrics and Gynecology Task Force on Hypertension in Pregnancy has released its evidence-based recommendations for treatment of women with hypertensive disorders in pregnancy. The ACOG Wisconsin section goes on record and op-ed to oppose legislative interference, including as 37 that forces women to undergo medically unnecessary ultrasound. So that's something we talked about earlier, the indications for the ultrasound, and those are the things that we will do because it's expensive, and also, it causes, the woman's radiation and to unnecessary procedures. So the indications that we need to take, and the ACOG actually has talked about that. And then also from the CMDA, the Christian Medical Association, the 2014 Winter Conference is coming up in February 21 to 24, 2014, and that's going to be in Bristol, Tennessee. And then some more news from healthcare includes let me up my slides here. Includes from Medscape, physicians warn about overdiagnosis risk, sleep quality affecting Alzheimer's risk, and ambulopia risk to kids, the new screening threshold that there are any new screening threshold that are needed, and then more data showing flu vaccine lowers CVD risk. So that's from Medscape, check it out. And then from the NCBI, new NCBI Insight blog post, joining PubMed Commons, the step-by-step guide. And Gen Bank Release 198.0 is available, and PubMed Commons is now live. So check that out. From the Agency for Healthcare Research and Quality, the new AHRC toolkit helps make care safer for patients in medical offices. From JAMA, they have a video, acute skeletal muscle wasting in critical illness. So they have another one on the effect of statin therapy on mortality in patients with ventilator-associated pneumonia. A randomized clinical trial. Statins are actually very important, and the video, the 19.0, the 19 minutes video can actually be able to help you learn about that. From the New England Journal of Medicine, trending news reform has actually been talked about in the news, and there are lots of changes, lots of things that have been done that has been aimed at providing providing Americans with good health care coverage. So I would invite you to check that out and be able to learn more about it and how you can be able to apply that into your classes and also as education. From the U.S. Department of Health and Human Services, top grades include from the American Heart Association, zero the sign of heart attack, and also for practical tips for coping with learning. And also in news, the HHS award grants for Hurricane Sandy recovery research, and it's also Wilderness Prevention Awareness Month. We talked about that earlier. And the Association for Nigerian Physicians in America is the convention in Charlotte. The president's summary can be read on the website, the Nigerian economy and its implications for healthcare delivery. You can read about that too. The 2013 band, one for Memorial Lecture, can be found on the website. And the recipient of the 2013 HIV Research Award, Ivo Oposikwe, and also what the recipient. You can be able to read about that on the website. From the American Medical Association, on the road with AMA President Adrian G. Hogan, she writes about the beginning of the transformation of medical education through vaccine and the cardiovascular outcomes. There's an article by Dr. Lydia that you can be able to check out. From Data Time, UCLA School of Medicine appoints Dr. Lee Shamik, Chief of Orthopedic Science Surgery. So that's actually trending in the news. Dr. Laszlo Nagy appointed George Chair and pediatrics. 15 years fine of orthopedic device launches and releases. So you can check all of that out. From the NRMP, we have a link for you to be able to check out the latest quiz. You can look at the math questions and answers. The math was the Twitter chat was actually pretty informative. It was actually if you had a lot of information about the organism and also about all the information that you may need to know about the math. From Lead Doctor, that's a physician hiring group. They have a lot of conferences that are designed to be able to help you understand how they work and also how they integrate their various policies into hiring physicians. You can be able to check out their website. They have instant access to job openings, and you can be able to sign up and be able to keep abreast of the openings. They have a lot of recommendations that attended some of the conferences and of the webinars that they actually I always highly recommend them. From Davenport University, they have Davenport University named the 2013 Great College to Work for. So that's where I got my MBA. It's from Michigan, and I would also recommend anybody to also get their MBA too. It can help me a whole lot in terms of administration, in terms of getting to know how healthcare, how administration, and also how healthcare reform and other healthcare laws affect you as a physician. And I would encourage anybody to check that out. Upcoming conferences, there are lots of upcoming conferences that are available, which are also listed on my web page. And all you have to do is go to go to the homepage and you can be able to check out these conferences. And I've actually registered for them, and I want to thank the sponsor and the host for providing such educational conferences that can be able to be used by healthcare professionals and be able to help them to be able to learn about trends in healthcare. And then so I'm going to talk about the one that is supposed to take place today. It's from the Institute for Healthcare Improvement I talked about that earlier. It's going to take 2 to 3 periods before time. So check that out, and there's still time to be able to register. And then at this point, I'm going to talk about what we do. At Dr. Drchikitomentoring preventive care practice, we offer free health assessments. We also offer free visits to community churches, to charity work. You can be able to take your blood pressure, your weight, your physical exam, your sports physicals. You can be able to check out some of the ones we've done in the past, and you all due to invite us. I'm also applying to some of the questions. I hope that we can be able to meet with you and be able to provide these free assessments. We also provide receipts. I'm also looking for people who are interested to kind of my team to be able to provide these health assessments to patients in their homes, and also we also offer counseling for depression, mood disorders, sexual abuse, elder abuse. Actually, a passion of mine. It's actually a very bad it's a very common thing that happens in society, and that's why education, which I offer, is actually very, very important. And then, and so that's what we offer, and I hope you can be able to invite us and make use of our services. I also want to talk about my work for the leukemia and lymphoma. There are lots of things that I actually taking place on the leukemia and lymphoma website, Light and Network Foundation. This is one that was organized by the Light and Network Foundation to be able to raise funds for leukemia and lymphoma victims. Lots of funds have been raised, which have actually gone into life-saving research. It has actually gone, I'm going into producing medications and also providing medications for families who have leukemia and lymphoma. And lots of success stories you can found on their website and how they network. And then also I have a team. I did not work last year, but I have a team this year. I have a 9 people team called the Drchikitomentoring, and we all have our web pages. We all have our Facebook pages, and these are the other solutions through my web page and also through our Facebook pages and also through our emails. And be able to donate. All the donations will go towards the Network Foundation. There are lots of something that have been organized to be able to create awareness. And right now there's a poster competition going on, which I know that my team is actually going to be part of and be able to win. So I invite all of you to take a shot at that. If you're creative, go ahead, create something about live the network that can be used on your Facebook page, that can be used use on your web page, and I can also be submitted. And then also there's a drawing for among the champions of skills, which is actually going to raise $100. And that drawing is actually for a TV. More details can be found on the web page. So my team is actually working to become a champion for skills by raising $100. So far we've raised $29. And actually that's $1, because we have $2 that somebody actually promised. So we are racing towards becoming a champion for ourselves by raising $100, and that way we can be able to get 50 shares. We can be able to get the link file, the shopping out for the first place. It's a fun activity, and the work will take place on the 27th of October by 5 p.m. The activity will start, and then by 7 p.m. the work itself starts. So I want to invite you to check all of that out on my page, on my Facebook page, and feel free to donate, feel free to be part of this